Shock is a very broad category, and I could go on and on and on shock. So I've opted to show you, sorry, just take off my mask. I've opted to show you a series of cases that give you an idea of the spectrum that we see in the cath lab when it comes to women with myocardial infarction and shock and some of the challenges we face. Here are my disclosures. Okay, so the first case is a 79-year-old woman, high blood pressure, asthma, presents with sudden onset chest and epigastric pain at rest associated with nausea and vomiting. She did have an episode of this discomfort 3 to 5 days prior that resolved, but we did not know that at the time. It was only afterwards, after the angiogram, that we were able to suss out this more of this history. She was very uncomfortable, writhing, vomiting. Her blood pressure was 70/40. Her heart rate was 93. She had minimal RALs, a soft systolic murmur. Her EKG showed poor R wave progression and submillimeter ST elevations in the anterior leads with inferior T wave inversions. So the semi-alert was called. Her chest x-ray didn't show any free air in the abdomen or any other large abnormalities. A POCUS showed that the entire apex and the anterior wall were severely hypokinetic. No effusion, no visible dissection flap, no aortic or mitral insufficiency. She was given aspirin, Plavix, heparin, and taken directly to the cath lab. So this is what I have. I'm expecting an occluded LAD, and this is what I have. There's disease in the LAD. It's after a large diag, but there's TIMI 3 flow. Circumflex looks okay, left main looks okay. Here, just another view. There's an aberrant takeoff of the RCA with some mild disease in the proximal segment. So I'm confused. Anyone want to do anything else? Well, now her blood pressure is 60 systolic. I'm giving her neo. She's not responding. She's vomiting up her aspirin and clopidogrel. Her belly exam is actually benign, on the table at least. She's just very, very uncomfortable. When I'm confused, I do an LV-gram. And she's got a VSD. So let me see if I can go back one picture. Not playing. So this is your traditional LV-gram. You see some opacification, looks a little funny. And so just reminding your colleagues to take another view. So taking that LAO view here to really see it. She went emergently to the OR and walked out of the hospital 1 week later. We felt like this was a pretty big save. This is a case of a 74-year-old woman with diabetes, high blood pressure, peripheral arterial disease with left toe amputation, presents to an outside hospital with 2 days of generalized fatigue and 1 day of anuria. Very atypical symptoms for at least cardiac or at least for an MI. She has, in her chart, it's documented everywhere that she's very hypertensive in all of her visits, in the 160s, 170s. Here, her blood pressure is 106/67, so the question of whether or not there's relative hypotension comes up. Her heart rate's 100, her O2 sat's 97%. She's warm, well perfused. I'm not hearing any murmurs. Her EKG shows inferior ST elevations with high lateral ST depressions. Her troponin, right off the bat, this is a troponin T, so this is 10.5 already. So in troponin I world, it's like 100 something. Her AST, ALT is greater than 700. Her creatinine is 5.7. She's transferred to our facility. POCUS shows inferior wall hypokinesis and mild MR. So I'm thinking she is presenting in cardiogenic shock, and maybe she has a VSD since she's been presenting for symptoms for 2 days. So I do a right heart cath with a shunt run, mostly because she cannot lie. She's having very much difficulty lying flat. So I'm wondering if her LVDP is quite elevated, too much to give a additional contrast in the LV. Her RA pressure is 18. You can see her filling pressures here. They're quite elevated. There isn't really a true step up. Her wedge was 30, but her cardiac index was 3.1. Her PAPI is normal, 1.5. I could not access her radial artery. She was very, very clamped down, and she has a single coronary artery, as you can see here. And what must have happened was she must have occluded her distal RCA that recanalized, which is why we're seeing such high troponins with a lot of thrombus in the distal RCA. But this is her entire coronary tree. Luckily, she did not have a proximal occlusion, otherwise we'd be in a lot more trouble. So we performed IVUS-guided PCI with the DES, and she had urosepsis, so her lab data eventually normalized and her blood pressure improved, and she did quite well. But this was a case where, I highly recommend using a right heart cath when patients are coming in with shock. You don't necessarily have to keep it in long term, but understanding what's going on can help us determine whether or not a patient would need additional mechanical support, particularly in women who are at higher risk of having vascular complications and bleeding complications. So trying to minimize the large bore access as much as possible, but utilizing it when you do need it. This is a case of a 40-year-old woman, paranoid schizophrenia, living in a group home, presents in March of 2020 in New York City with a cough, shortness of breath. Chest pain for a day, heart rate's 112, blood pressure is 124/78, and she's quite hypoxic, 84%. This is her chest x-ray, her baseline EKG, her lactate's normal, troponin's negative, she's COVID positive, D-dimer and HSCRP are elevated. She's admitted with COVID pneumonia and ruled out for ACS, given DAPT. The next day, she develops chest pain at rest, and she has this EKG, a new right bundle branch block, some ST elevations in the anterolateral leads. Her POCUS shows an apical hypokinesis. She gets unfractionated heparin. We're called. We tell them to emergently transfer her to our center. We take her directly to the lab. Her heart rate's 113. Her blood pressure is 165/118. Not on much medications. I don't think she was on any pressors at that point. Her lactate was 1.6. Her O2 sat was 93% on 6-liter nasal cannula in the setting of COVID. And we did call the COVID intubation team, but as they were getting their equipment, we just decided to proceed because at that time we were still new to the whole process, and it took us some time to get the team together with all the resources. So this is what we have, right radial access, RCA is okay, totally occluded proximal LAD. A ton of thrombus. We've given bivalve ticagrelor, 2 compliant balloon just to low pressure to establish flow, and you can see there's extensive thrombus across the entire length of the LAD and the diag. We give nitroprusside, do mechanical powered aspiration. There's no improvement in the thrombus burden. This was our first experience with the real COVID MI. So I gave intracoronary lytics. I had read about it, 11 years in practice. I'd never needed to give it, and this was the first time I did give it, at least in the coronaries. It did allow some resolution, but you can see a lot of that thrombus has just really gone downstream. So we did repeat aspiration. She's got refractory hypoxia. We're finally able to intubate her. Second wire is placed in the circumflex. We're at least able to deploy and stabilize the proximal lesion with a stent. But now she's 40 years old. She's a 40-year-old woman. She was clamped down. So as soon as she was intubated, all of that adrenaline was, her adrenergic tone was released. Her blood pressure started to spiral downward. Her pulse pressure, which was relatively okay, but still somewhat narrow to begin with, was beginning to narrow even more. So we obtained ultrasound-guided access, put in a balloon pump, mostly because we had been hit hard that weekend and Impella had already been used in 3 other patients, so we were waiting for a new console to come into play. While doing all of that, she's already reaccumulated new thrombus in her recently implanted LED stent. We give some more IC lytics, and that helps resolve some of the proximal thrombus. We give 2B3As, nitroprusside, epinephrine. There's still a little bit of no reflow in the distal LAD, but at least there's flow in the diag. Right heart cath shows that the cardiac index is 1.7. As expected, her wedge isn't very high. Her hypoxia was really from COVID. We were able to get another console in, and the patient was put on Impella support. Unfortunately, because her COVID pneumonia was so severe, she did die a few days later from respiratory complications. And then the last case, I'm going to show this case. It's actually a 54-year-old man. He's got CAD. He had an inferior wall STEMI 3 years prior. Presents with 2 hours of chest pain in the setting of aspirin noncompliance. EKG shows inferior ST elevations. And in the ED, the patient has a VFib cardiac arrest, multiple shocks, amiodarone, lidocaine, incessant VF. Now, if this was just even a few years ago, I wouldn't have been able to take this patient to the lab. I would have said, okay, you need to stabilize the patient so we can take him into the elevator up to the lab and do something. But we now have the mechanical CPR system. In our case, we have the Lucas device. And so in this case, for probably the first time in my time where we took a completely unstable patient in incessant VF on the Lucas machine straight up to the lab. So my colleague got right femoral venous access and left femoral arterial access under ultrasound guidance with a 25 French and a 17 French sheets for ECMO cannula support as soon as he was stabilized. While he was getting ultrasound guided access for the ECMO cannula, I was already getting right radial access and bringing the JR4 guide up so that we can very quickly open up this artery. As soon as he was on ECMO, we wired the lesion. It was a distal RCA stent thrombosis, did IVUS-guided PCI. And remarkably, this patient did it very, very well. Basal and mid-inferior wall was severely hypokinetic on the follow-up echo, but other walls were hyperkinetic. His EF was overall normal, and the patient was discharged home. And I said this was a young person who, if had presented even like a few years ago, would have just died in the ER, and we wouldn't have been able to bring the patient up. But it did get me thinking in the context of this symposium, with those large cannula, what would that have been like if this was a woman and getting access for ECMO? So for me, just a few take-home points and then a few points food for thought. When feasible, if an LV gram can provide additional information, particularly VSDs are often missed on POCUS, and we do need to keep that in mind. As we've talked about throughout this symposium, women do tend to sometimes present later, tend to overlook the symptoms early on, and then what the symptom that they're presenting with is the actual rupture, the mechanical complication. And very often, unless you're looking for it, you will miss it on a POCUS. I think a right heart cath can be helpful in many, many ways. It can help you rule out complications, but it can also help you determine the etiology of the shock in an emergent situation. And most importantly, it can help you determine if you need support or not support. I showed you two cases, one case where she ended up not needing support and one case where support was needed. And if you do need support, what degree of support do we need? We often either underuse or overuse, and then when we do use, we sometimes are not using the right amount of support that we need, where you may need a ECMO support rather than an Impella, or you may need, just a balloon pump to get through. Ideal to have radial access in the third case with all that thrombus, the lytics I was giving, the Kangor, the 2B3As I was giving. It was very helpful to have radial access to reduce access site complications. But if support isn't needed, then you're at least using one femoral arterial access site under fluoroscopy and ultrasound guidance, because women are at higher risk of having vascular and bleeding complications. And then some food for thought in terms of MCS and shock, or mechanical support in shock. If women, we have tons of data showing that women are higher risk of access site and bleeding complications. Do we need those large cannula for ECMO? Can we scale it down and figure out a way to use smaller cannula and still provide the degree of support that we need? Impella's come out with a smaller French device, or at least in the study phase, and hopefully will be FDA approved to provide a smaller French device. But we do need our device companies to be thinking about going smaller with their to reduce some of these potential complications, particularly in women. Thank you.